The most important thing I have done in my life was be Dr. Kelly's good friend. We worked together for many years, and we treat many of his patients already, and some of your faces here are familiar to me. Not many, but many. And well, it has been a great pleasure working with Dr. Kelly. And my role on the pituitary work has been always complement and help Dr. Kelly in the difficult problems that after he has done his operation, it was not possible to cure the problem. I try to come in and help with the cure. Many times we achieve that working together, and sometimes we fail, but we keep at it. He keep on operating, and I keep on irradiating, and hopefully we are offering a good quality of life for the people that suffers from pituitary adenomas. What I'm here to do for you is just explaining a little bit what I do and how that can apply to your situation or to the situation of a loved one that you have here or at home that has a pituitary adenoma that was not cured by the surgery or by the medication for that matter. I'll give you a little introduction, and then I will talk with you about all the radiation techniques available. If you stay there, I won't be in front of you.
No, it's okay.
It's okay? Yeah. So then I will talk about something that's called radiosurgery, then stereotactic radiation, the rationale for us to do this to a pituitary adenoma, and then what we have done at UCLA over the years and some conclusions. Radiosurgery, by definition, is if we give one shot of radiation. To do that, we have to be extremely precise, and the technology until now it requires that you put the frame in the patient's head, and that with local anesthesia we can apply the frame and hold it in place tight. Patient will wear that frame during the treatment, which is consistent one day because it's a single shot. So we'll have MRI scans, CT scans. We fuse those images together. We do the calculations and we do the treatment. So it's a period of about 6 to 8 hours that the patient will wear that frame in the head. If we, instead of giving a single fraction, we go to many fractions, 5 weeks. 5 weeks mean we work only from Monday to Friday times 5, about 25 fractions of radiation, a little bit at a time. Why do we do that? We do that to protect your vision or protect anything else we need to protect. It's the best way, excuse me, I can't speak. Do you want me to speak louder?
Please.
Yes. The best way of protecting normal tissue from radiation is give it a little bit at a time. Shoot the tumor and the normal tissue a little bit at a time. The normal tissue tolerates quite well a little bit at a time. The tumor doesn't. So the tumor ends up dying and we protect the normal tissue. When the normal tissue is not mixed up with the tumor, then we give one high shot, and that's very effective. I'll be discussing with you when we do this or when we do that, depending on the situation. And I will talk a little bit the results and then the complications. If you go to an operation, not many times you get out of there without any problems. You may have a little infection, leakage through the nose, or some problems with the operation. Same thing here. There are problems with it, and I want you to be aware of those problems. So, what are we trying to do with the treatment? Obviously, stop the tumor. With radiation, many times the tumor doesn't go away, but never grows again and never produces hormone again. So what you have is that imaging that stays in the MRI, and that is basically a scar. Stays there, is dead. And we doctors don't worry about it. Patients may. Some people want their head clean. Maybe they want to even us to take the brain because the brain is not very good. So we feel that if we stop this tumor and don't disturb hormones, don't disturb the vision, then we have done a good job. Preserve vision, preserve the endocrine function. So we want to kill the tumor and maintain the pituitary working as well as the hypothalamus. And we want the patient to continue thinking normally without any decrease of any capabilities. So we can do that quite well. What we have hard time sometimes is control a tumor that's overproducing hormone, like in the Cushing's disease or in the growth hormones, acromegaly, and prolactinomas. Those are harder to treat than the ones that don't secrete anything. We are quite successful with the growth hormone producing ones and also the prolactinomas, but not very successful with the ones that produce ACTH, which is the Cushing's disease. So how do we think about it? We think about surgery. Surgery is better because surgery will give us a piece of the tissue. Will immediately take the pressure away from the nerve, so the vision comes back to normal. And also, if it is a tumor that's secreting hormone, and the tumor is large, and if you can cut 90% of it, the production of hormone will go down at least 90%. So you've got an effect immediately. With radiation, you really don't get that. So what the patient wants is just not to have surgery. We know that. So they want to get medication first. And if medication fails, then they usually don't want surgery. They would rather come to something like focused radiation first because it's not so invasive as surgery. However, surgery does a better job. So usually we say, no, you go to surgery first because you'd be better served, if possible, with the operation. And the operation that Dr. Kelly is doing now through the nose, you know, patients never complain to me much about it because they complain to him. When they arrive to me, they have already forgotten because I think you do forget if you get a good result. When you arrive to me is because a little bit of tumor is still there and I need to do my radiation. And I would do then the stereotactic radiation, as you see, as a third option. Scale of things. So if you have a pituitary adenoma, you all know you saw an endocrinologist. The guys hang around with you for a while. Help, didn't help, maybe help, but at least that guy is extremely important to maintain your hormonal levels in the right situation and try with you all the medications available for pituitary adenomas. The ophthalmologist should always get involved, at least to monitor what's going on. Radiology, you got a lot of scans going on. Neurosurgery, Dr. Kelly and myself will get involved in the last instance, and then the oncologist, the radiation oncologist will get involved because they work with us, and if there is any malignancy involved with the tumor, then they are the person to deal with it, and then we do the stereotactic radiation. Radiation, what is out there, what is available? If you come to UCLA with a pituitary adenoma, you're not going to have conventional radiation therapy anymore. This is the past. Why I say it's the past? Because you irradiate large areas of the brain, and I'll talk with you about the complications. Was it effective? Yes, extremely effective, because pituitary tumors don't like radiation. If radiation hits them, they die. So conventional radiation was very effective. However, with important side effects. Well, now we have what is called a stereotactic radiation, which focuses to the tumor. Either focus with one shot, I described it to you, the dose is usually more than 14, and the patient is in the frame. And that's the machine there to irradiate. This is a mask, allows us to put the mask many times. This mask is designed for the patient face, so the person cannot move more than 2 millimeters inside of that mask. So if we put this mask on, it's because we are doing many fractions. If we want to give one high shot, then we pin it down because there's no room for 2 millimeters more. Again, this one, stereotactic radiotherapy. The other one, stereotactic radiosurgery. Well, what are the limitations here with radiation in general? Conventional radiation, little bit of the time, large areas of irradiation, has a very moderate effect in decreased hormone level. If the goal is treat over-secretion of hormones such as Cushing's disease or acromegaly, then this has a very slow effect, may have an effect that it takes 6 to 10 years to get the hormones at our level. If nothing is available, we got to do that. It has a very low effect in the growth hormones, a little bit better than the other ones, and may take years, as I mentioned to you. Now, the risks of conventional radiation therapy. Visual deficits, rare. It's very safe in relation to the visual deficits because we have learned how much radiation we can give and preserve the vision. And that's almost 0%, and if we give less than 2.5, this unit is gray per day. So it's extremely safe. The other side effects of conventional radiation therapy, which will become a little bit more important. When you look at the dose, if you give more than that, you got 18% problems in the vision. So that's basically not acceptable. Nowadays, anything that's more than 5% or 1%, patients don't want to accept the therapy anymore. And it's correct. There is enough technology there to avoid a lot of the complications. So we should.
Excuse me, question. What's the definition of G sub y?
G sub y, it's called gray. Is a unit. Gray is a unit of radiation that's absorbed by the patient. 1 gray is equivalent to what it was called rad, 100 rads.
100 rads?
Yes.
Okay.
Okay, so 100 centigrade would be like 100 rads. So the overall visual deficits with high dose of radiation that was done in the past is 9% with conventional radiation therapy. Cataract, 9%. If you irradiate your eye and you can get a cataract. So we can't accept that. So that's why I told you we don't do this conventional radiation therapy anymore for pituitary adenomas. Panhypopituitarism, you know what that means? No hormones. We killed all your ability to have hormones. Some of you take replacement. Take replacement for growth hormone, replacement for sexual hormones, or even hormones as ACTH replacement. And those, if you are using conventional radiation therapy, 50% of the patients will have that problem already in 5 to 10 years. So we want to avoid that. Mainly people in the age of reproduction, we want to keep that capability. White matter changes are important. White matter, the brain has gray and white matter. So if you have white matter changes, meaning that you are decreasing your brain capability. You know, your cognition is going downhill. So if you radiate large areas of the brain, you will get that. So no conventional radiation therapy. Conventional radiation therapy is still used only for cancer. People that will die, they will die in 1 to 2 years at most. So the survival is short, so they still do radiation therapy. People long live 50 years, like pituitary adenoma people will live, so we want to avoid any large areas of radiation to the brain. Well, I'm talking about cognition and memory deficits. It's poorly documented. The doctors that have treated patients with this conventional radiation, they didn't really look at it very much. Basically, we know because patients complain, oh, my memory is bad, now I have to write everything down. And this usually happens 2 to 3 years after large areas of radiation. So this is a true occurrence. Other problems when you irradiate large areas of the brain is new tumors. You can come up with new tumors because you're irradiating so many cells, and then you are increasing statistically the chance of having a new tumor. That runs 1%, about 2% at most. 2% in 10 years. If you have to wait 10 years to have a 2% chance of having this, if you use conventional radiation therapy, can you imagine if you use very focused radiation, this will go down way, way, way down. Actually, we never have seen it because the statistics led to this to be very rare. So this is an example of conventional radiation therapy. Those arrows that are coming around here, is that how things were done until 1985. Patient come with a tumor that's this big, this is the tumor here, and we'll receive radiation to this whole part of the brain. Well, this part of the brain here is where memory is, right here. So that's why you got a cognition and memory problem. So we don't do this anymore, and I'll show you what we do these days. Well, this particular patient was treated in Germany at the wartime, 1945. He showed up here at UCLA. This was reported in 1998 by us here at UCLA. And the guy presented with 3 different tumors 40 years later because of this type of radiation. So it does happen if you wait long enough. Now, if you're 70 years old, you have a whole brain radiation, you're going to die when you're 90, you're not going to have time to see that happen. Well, what is this terrible word here, stereotactic? It's stereo and it's a tactic of going stereo in all directions in the same spot. And this was started in the beginning of the last century, 1906. Some English surgeon and a physicist designed this little box that you can put patient's head inside, and you can calculate everything with precision inside of the head. Well, this one here was designed for the rabbit. First in the laboratory in 1906, and it took from 1906 to 1947 for the first patient to be treated. 40 years. So this was studied for 40 years before a surgeon had the courage to put someone's head inside of this. So, and nowadays it's not like that. If we find something in the laboratory today, in about a year or two, we're already at the patient level because of the internet and information age. We learned what the guy did in England. If you did yesterday, we know today or even earlier, because if you put in the internet, there we go, oh really, Google it, and that shows up. Well, now we use this technique, and that technique allow us to, that stereotactic there, and then allow us to go to a point precisely, and moreover, we can shape the radiation to the shape of the tumor. So this is 100% of radiation there. This here is already 5% of the amount of radiation that was going there, so the brain around it is getting almost nothing. So it is extremely safe to have this treatment because you're not really getting a lot of radiation to your normal brain here. And more, we can go precisely. It's so precise now. This is a 3 millimeter. 3 millimeter diameter, right? 3 millimeter diameter is something that is like looking at a little hole in your finger. And we can put a beam like that. If you have a very microadenoma in the pituitary, you can just shoot that if needed with extreme precision. And change the molecule of DNA of those cells in a way that they cannot reproduce. They end up dying. So if the tumor goes to grow, the cell dies and the cell is absorbed. The trash is absorbed by the body. And that shows you why it takes so long for a tumor to decrease in size and respond, because it depends on the cell cycle. Well, pituitary adenomas are benign tumors, so they divide very slowly. So when you hit those cells, it will take a period of time for those cells to start to divide, and when they divide, they die, and when they divide, they die, to a point everybody's dead, and you have only this scar tissue. If you Google radiosurgery, stereotactic radiation, then it comes a lot of things there, and you're just going to get confused. Because there is protons, there are cyclotrons, there are photons, there are carbon ions, there are a number of techniques, and you got to make your mind about that. Cyclotrons make a beam that is made with particles. You take an atom, you have the electron going around it, you got the nucleus there with neutron and proton. If you take an atom of hydrogen, I just described to you what it is. It's only one electron. And if you take that atom of hydrogen and we inject inside this room with magnets rotating around it, to make all the atoms rotate, you rotate that the electron is spit out. And now you got this nucleus as a particle, is a proton. And if you put it in a pipe, if you put a pipe in that rotation mode, all the protons will just go right through that pipe. And if you take that pipe and point in the patient's head, it goes right inside of the patient's head. And if you calculate properly where that beam should stop, you can calculate that with the proton. And by putting water in between the pipe and the patient's head, you get all the way in a way that to stop to the tumor. And if you put a little bit of water, it will cross the head. If you put a lot of water, then it would stop where you want, depending on how much water. So that's how we do with the protons. We used to do it. Now there's ways of doing this in a more elegant way that just get the patient wet. Other ways of doing this is gamma ray, gamma knife. You have heard of that probably. X-rays, Linex, cyber knife. They all are the same thing. They all use photons, which is a particle, not quite a particle, but a little amount of energy that you can direct. And I described this to you. This is a pipe. This is a patient with a pituitary adenoma. This is probably 80 when I was doing this kind of work. The cyclotron is rotating here. This is the pipe going there. This is a bucket of water. You got a party balloon, and you put the party balloon in between the pipe and the patient, and we connect the balloon to the hose here of water, and we lift the water up. And the water goes inside of the balloon, so it doesn't wet the patient. Sometimes we pull up a balloon here and there. When we did that, then we got the proper distance we need from the pipe to the patient with water. And this device will bring the patient close or far from that pipe. So that was how precise this thing was. And it was precise. It's precise to better than 1 millimeter, because we're irradiating tumors with doses higher than to be used today. And we were not getting people blinded for many years, more than 3,000 or 5,000 patients. 3,000 were treated at the Mass General Hospital, the Harvard cyclotron, and another 1,000 or 2,000 are treated here in the Berkeley laboratory cyclotron. Well, the beam goes like this, and it stops. It's the only beam that stops, is the beam of proton. And we can make this beam stop inside of the pituitary gland of that patient. Well, water was a nice way of doing this, but then we came up with this idea here. We put this piece of plastic that had similar consistence of water, and now we could design the patient's tumor, give that drawing to the computer. The computer will tell a machine, a drill. The drill will come and drill the plastic with the same shape of the patient's tumor. And we put this plastic on our here. And when the beam shooter, now we got the shape of the tumor on the other side. So it was a great development already at that time. Now we can do those things all with the better computer techniques. That way I just showed to you thousands of patients were treated. And most of them were patients with breast cancer. At that time, it was found that the patient had breast cancer, the patient had spread of the tumor to the spine. They had a lot of pain because the spine, the vertebra would break. Got terrible pain. There was no form of treatment, no good drugs. So they shoot a high dose of radiation to the pituitary gland. Pain will go away. Until today, we don't know why, but it worked. So thousands of patients are treated in that way. Mostly here in California. Well, in 1981, UCLA bought the Gamma knife. Was the first one in the country. Came to UCLA from 81 to 90. This treated a number of patients there. This is a little newspaper. This was the Bruin. You probably have seen the Bruin newspaper there at UCLA came up. UCLA has an unusual knife. It was the Gamma knife then. So Gamma knife from until 1990, we got this Linex scalpel. You know, it's a new machine rotated like that and did similar work to the Gamma knife, but already computer controlled. We got a dedicated machine we called X-knife at the time. It was a lot of patients with X-knife. Cedars-Sinai still has an X-knife. We stopped using the X-knife in 1997. We used it 1 year only because this new machine came, Novalis, that could shape the beam. So we started to use Novalis in 97. We still are using our Novalis. And we just bought a new Novalis that the shape does everything that the old one does, plus does a CT scan of the patient, and the patient is laying down there, so we confirm where the tumor is and everything is going well. And plus, you don't need frame anymore. You don't need to frame the patient because there are other ways of controlling for precision better. So this happens in up 20 years, 28, 27 years. A lot of progress has happened in this field, and they are all basically with computers. So this is the 1997 development in which this machine is rotating, and we were shaping now. As the machine sees the tumor is changing, not the tumor is changing shape, but the vision, the beam view of the tumor changes. So it changes the shape, and it automatically will be controlled, the radiation, to avoid the normal tissue. Well, this is a new machine that does a CT scan, and it just rotates like that. It is one run like that, you treat the tumor. Done. And plus, there is an imaging that we are seeing. You notice here the patient has only the mask, and you can treat the tumor there inside of the head in red, but you can treat anywhere in the body too, so we can be very precise as we are in the brain, we can do in the body. And why can we know that? Because we have the system here. We have a little camera, and the camera is shooting an infrared light. That infrared light is taken back by the camera, which are these detectors here. And now you have, when it goes in, it comes back and makes a triangle. And if you get 3 or 4 of those reflective markers, now you got three triangles. You can calculate anything in this space. And now if the patient moves, we know. If the patient breathes, we know. So the machine just will turn on only when the tumor is right in the spot. So this turns the treatment very fast. Well, not really the case with the pituitary adenoma, because they had the spin down there with that mask, so there's almost no movement. So the treatment is even faster. This is how the Gamma knife used to do it. They got 4 shaped beam, they're round. The old Linex, we have pipes, many pipes. The beam shaper does a shaping of the beam in that way. There are leads that come and make the shape, and those leads are motor controlled, computer controlled. That's why when it rotates, you can shape it. You can go from 3 millimeters to 100. With this Novalis 3 from 100, those Gamma knife, Linex, and Cyber knives have the limitation of 60. It's okay for pituitary adenomas because pituitary adenomas are not 6 centimeters in size. So Gamma knife, Linex, and Cyber knife can take pituitary adenomas and treat quite well. This here tends to decrease the amount of radiation to the normal brain, and also can modulate the beam. And we can, the story I described to you, how the brain can stop and be modulated of intensity, can be done because of this leaves that depending on the time that you let one of these leaves stay in front of the beam, you modulate it, you decrease the amount of radiation that passes. So if you want to protect the vision, you get those leaves stop right in the direction of the optic nerve, and you protect the optic nerve in that way. I think you may have to touch. Can you? Is that a going arrow over there? I don't think it will.
Or here?
I think I'll keep on repeating this rotation here if I continue. No,
Over.
right?
Oh,
Yeah.
Go up.
Go ahead. Yeah. Go ahead. You went back. I think.
Oh, back. Sorry. I'm dyslexic.
Yeah, well, there we go. Oh, okay, so when we do this, use all this technology in people's head, you know, with pituitary adenoma. Here's a pituitary adenoma. Here's the optic nerve. Vision is passing right here. This is some of you have heard this from Dr. Kelly. Oh, I couldn't take your tumor completely because the tumor was inside of the cavernous sinus. Cavernous sinus is right here. And if the tumor invades there, then we can't remove it because all the nerves that move your eye pass through that area. So the tumor is embedded in the nerves. If you take that tumor out, you take the nerve out, then you're going to have cross-sight vision. And more, this black spot here is blood passing through the carotid artery. And then if you make a hole in the carotid artery, you're going to die with blood gushing out of your nose. So Dr. Kelly doesn't touch that. So he just sent the patient out to say, oh, Tony, take care of that. So that's the only time I really have a chance. Or when the tumor is recurrent. You know, if several operations were done over and over again. So then I just stopped. No operations needed anymore. In places where inaccessible, I already told you when. Or if the person is so sick with heart problems, high blood pressure, wherever, that cannot have an operation, cannot tolerate general anesthesia. In that case, I'm called to help. There's an example of a nice lady here. She was 33 years old when I met her. She had been operated on through the transsphenoidal route, old-fashioned through the mouth. Did you get it? Yeah, it was. So, 1989, 1990, you see here the tumor. Is the tumor growing? Keep on growing, 1990. 1990, I started to work at UCLA, so now it's 18 years.
Speak up a little.
Yeah.
Speak a little louder.
Can you want to switch him?
Sure. Yeah, that's a good idea.
Yeah.
And if I
Wanna
speak
switch
louder,
with I?
I'll get a dry
Yeah.
mouth because.
You want to
And
sit up front? That
may I
way?
have one of those
Yeah,
bottles?
switch
It'd
chairs.
be healthy.
Yeah, switch chairs, no, switch chairs.
Thank you.
Everybody.
No,
No,
that's
you're
fine.
okay.
I thank you very much.
Not a problem, it's going to Dr. desalles to have their voice better than
Brother, if I start to scream, you got it. It's already loud. Also, at this point here, we focus a high dose of radiation to this person. And at that time, 16 went to the border of the tumor, and 32 went to the center. And gray. You remember the gray. 32 in the center of the tumor, and there was the tumor going down in size. Here, 93 was dead inside, and then the darn thing shrunk like here, and then disappeared in 98. This lady moved to Virginia, and there she found a husband and got pregnant. Now this is to tell you that the gland was still working, not the husband, the gland. Another example of a tumor that was treated. The gland is in this side here, and the tumor is gone. It's empty with the focused treatment to it. Another example here was like this. 5 years down the road, it's like this. And that's the dose we gave there, 17 gray or 1700 centigrade. More, same kind of. So, and I want to call your attention to you that this was treated like this because you cannot operate because it's inside of the cavernous sinus. That's why we did like this. This guy published this. This fellow here, Marco, published this in 2000, 8 years ago. What he did is he didn't give radiation to the patients after the operation. In 5 years, 20% of the patients had a large tumor that needed treatment. In 10 years, at least 44% of the patients. If you give radiation, that falls down to 1 to 2% of the patients that will need treatment. Now, growth hormone, high levels of growth hormone. If you give radiation in 12 months, focused single high dose, you get 43% of the patients got normal already, amount of growth hormone. If you wait for 2 years, more than 2 years, you got 95%. And more than 3 years, then 96% of the patients now have a good control of hormones. So it takes time. That's why radiation is not the first choice.
Done what?
The first choice is surgery because it takes time with the radiation. It takes a time for the growth hormone get to a normal level when you give radiation. So there at UCLA, this is developed together with Dr. Kelly. We do surgery first. After surgery, we observe if the tumor is growing and we see a little bit of growth. Then if there is a hormonal problem, surgery again if needed, more than one time. And if surgery no longer becomes possible and there is optic nerve involved to it or carotid artery, then we have to do the radiation. And then if there is involvement of the optic nerve, then we will do a little bit at a time, fractions. If there is no involvement, then we give a single shot. Why we prefer single shot? Because it's more effective in taking care of the hormones. Because a whopping dose of radiation at one time has an extremely high effect comparing with the fractions. And if there is a hormonal problem, we really try to go to the single shot because it's more effective. 100% of the patients treated, some patients will start to have relapse with time. So we may need to complete with more radiation or complete with an operation. And this is about several years of follow-up at UCLA. So that's a situation where we use the little fractions of radiation. There is the tumor, and there is the nerve. So they are together. So I have to protect the nerve, and I have to give a little bit at a time. If you look at all the patients treated at UCLA from 1991 to 2006, a little bit more of the patients receive the fractions, this single shot of radiation. This 87 patients here. And why is that? Because what is sent to UCLA are the difficult stuff. It's the ones that are embedding the nerves and hard to treat, so we end up having to give the fractions of radiation. Here's an example of a 70-year-old man that the tumor was pressing the nerve, had decrease of vision, didn't want an operation, so we did little fractions at a time, and follow over time. 2 years later, the nerve now is decompressed, the vision is back. But it takes 2 years. If you had the operation, immediately. will get better. If you give one shot, and this includes the people with hormonal problems, then we have a failure of 12%. We got to treat again. Large majority of the tumors decrease in size with a single shot, but some of them stay stable, don't change. It's different when we give diffractions of radiation. Or non-secreting of them, we get a large number of stables decrease and some failures in there, and then we give fractions of radiation on top of that. If we fail, we can't treat again. It's because we didn't want to take too much risk, decrease the amount of radiation. An example here of a patient that was a 58-year-old, was treated in '93 with a single shot of radiation, and then had a recurrence. We retreated later on in the year 2005. Now, when you give the fractions of radiation, we are extremely successful. We are successful in stopping the tumor from growing. We are not successful in stopping the hormonal problem. Stable, a large portion, and not decreasing in size, a large portion too. However, 0 fail. So 100%. 100% is pretty good. I don't think you can get better than that. No tumors disappearing, but no tumors needing treatment after that. 44-year-old guy, 91, had blurred vision, and then had a prolactin of 200, had operation. 97, second operation, treatment, 25 fractions. There is the tumor, ugly looking tumor, and then control here with a long follow-up of out 6 years, showing complete control of the tumor. So it's quite effective. Overall tumor control rate, including non-secreting, secreting, and fractions and non-fractions, we have a 92%. So it's pretty good. So you should be confident that this tumor not going to grow inside of your head to a point of killing you, because we can't stop it the majority of the time. If it's non-secreting, 94%. If it is a growth hormone secreting, 100%, we can control the hormone if you wait long enough. If it's a prolactin, much less, 57. So prolactin is much more resistant to radiation. And if it's an ACT agent, we are successful 33% only. So surgery is better here, actually better here too, because it's faster. But still, it's a good option. So we are really controlling the raging hormones. And you see this guy has a lot of hormones, and we are controlling this kind of people. So look at that.
That's cute. Oh no.
That guy does need some radiation. Well, the techniques available nowadays has improved immensely the quality of this treatment. So we can really treat with almost no side effects and almost 100% control rate. So this is pretty good.